Serological detection of viruses. So virus typical structure, they are submicroscopic particles, which means that they're smaller than what you could see under a microscope. They have a core of DNA or RNA, and this could be double-stranded or single-stranded. Then that's surrounded by a protein coat, and sometimes it's surrounded by an outer envelope. They're obligate intracellular pathogens that rely on the host cells for their replication and survival. They present as freely circulating particles and intracellular particles. So the typical cycle goes through the attachment, then they will penetrate, then they will uncoat, then they replicate. So you're going to have transcription happen, translation happen, then new viral particles are going to assemble, and then they are released from the cell. And this is all within the host cell. When they do enter a host cell, they stop the host cell's function. So if it's a liver cell, the liver cell can no longer do liver things. The liver cell is converted to a virus-producing factory. So it stops your host cells from doing what it normally should be doing and switches it to a factory of virus-producing organelles. Immune defenses against viruses, so there's innate defenses such as the skin and mucous membranes, recognition of PAMPs on virus-infected host cells, interferons alpha and beta, humoral antibody responses, antibodies attack free virus particles, viral neutralization, opsonization, complement fixation, ADCC, cell-mediated immunity, interferon gamma and IL-2 produced by Th1 cells, host cells containing intracellular virus destroyed by CTLs. Viral escape mechanisms. So there's ways that your viruses that try to infect you can escape recognition by your immune system. Mutations result in the production of new viral antigens, such as influenza. That's why every year we need a new flu shot, because every year new viral antigens are present. And the flu shot's really just a prediction of what the most common viral antigens are going to be in circulation. Now, we do a really good job at predicting, but sometimes we predict the wrong things, and even after getting the annual flu shot, you end up getting the flu. Usually it's a milder case, but it's possible. The virus blocks the action of the immune system components. So HCV, hepatitis C virus, can bind to C3b to prevent that from happening. Suppression of the immune response. So cytomegalovirus, CMV, reduces MHC class 1 expression. MHC class 1 is what holds up the virus to your immune system. So once the virus gets into your cells, it gets broken apart and held up to your immune system by MHC class 1. And then your helper T cells, cytotoxic T cells will come and recognize that and be like, oh, this cell is infected, we should kill it. Cytomegalovirus reduces MHC expression in your cells. Immune function altered. So Epstein-Barr virus stimulates polyclonal B cell activation, and a latent state is established. So varicella-zoster virus remains latent in nerve cells. And those are all just examples of how the virus can hide inside of your body. Laboratory testing for viral infections, usually serological tests, distinguishes between current and past infections. So if you're IgM positive and IgG positive or negative, current or recent infection or a congenital infection. IgM negative, IgG positive, past infection, or maybe you've been vaccinated against a particular virus. Antibody titers are used to monitor the course of infection. They're also used to determine immune status. So you do an antibody titer to make sure that if you've been vaccinated in the past, you still have adequate immunity against the virus. So assess immune status, that's what I just mentioned. So virus-specific IgG indicates immunity. And then there's molecular tests. Molecular tests are way more commonly used than a lot of the serological tests, but there are some applications to the serological tests too, especially for like screening tests or just a quick yes or no, do you have it or do you not have it type test. But molecular tests are a lot more commonly used and a lot more accurate. Hepatitis viruses. So there's a bunch of different hepatitis viruses. When you hear hepatitis, you may know that hepat is referring to the liver, itis is inflammation. So all of these cause like generalized inflammation of the liver, but they cause that inflammation to various extents. There's some viruses that are transmitted by the fecal oral route, like hepatitis A and E, and some that are transmitted by the parenteral route, B, D, and C. So that's blood contact, or sometimes it's by sexual contact. Clinical laboratory findings, so general flu-like symptoms early in the infection, pain in the upper right quadrant of the abdomen, that's where your liver is, hepatomegaly, so swelling of your liver, and liver tenderness with progression, jaundice, yellowing of the skin, dark urine, light feces, elevated bilirubin, and liver enzymes, for example, ALT. Hepatitis, and that's for all hepatitis viruses. So now we're going to get into the specific hepatitis viruses and how they're detected. So hepatitis A is an RNA virus. It's transmitted by the fecal oral route, close person-to-person contact, ingestion of contaminated food or water. It produces acute hepatitis in the majority of adults. Infection in children is usually asymptomatic. Formalin inactivated HAV vaccine exists. HAV immunoglobulin is recommended if unimmunized person is exposed. Acute infection indicated by a positive IgM, anti-HAV antibodies. Immunity indicated by positive total anti-HAV along with a negative IgM anti-HAV. So what that last sentence means is that if you want to know if you're immune against HAV, hepatitis A virus, it's indicated by having a positive total antibodies against HAV, but a negative IgM anti-HAV. Because IgM would indicate that you have a current or a recent infection. Because if you think about the immune progression, the first antibody on the surface of the B cell that's initially going to do that recognition would be IgM, or in some cases IgD. But IgM is much more active in that function. So once you start producing the IgM antibodies, eventually those B cells are going to proliferate into plasma cells and go through that immunoglobulin isotype switching. And when they do that, you're no longer going to be pumping out IgM, you're going to be pumping out IgG. So as the course of the infection continues, you're going to see less IgM, more IgG, and once the infection's gone, all that should really remain in the bloodstream is the IgG antibody. And that type of antibody is going to give you pretty long immunity. Hepatitis E virus. It's another RNA virus, but it has 4 genotypes. 1 and 2 are transmitted primarily through ingestion of feces, contaminated drinking water. 3 and 4, consumption of infected pork. Mostly asymptomatic or self-limiting. Severe infections are possible in pregnant women or immunocompromised people. Acute infection is indicated by IgM and anti-HEV. IgG anti-HEV indicates past exposure. Can detect HEV RNA in the blood or stool samples during acute infection. HBV, so hepatitis B virus. DNA virus transmitted through parenteral or perinatal routes, sexual contact, IV drug use, occupational needle stick injury, or during the birthing process. Acute infection, symptoms increase with age. Chronic infection persists for 6 or more months, occurs in 90% of infected infants, 10% of infected adults. It increases the risk of liver cirrhosis or hepatocellular carcinoma. Hepato is referring to the liver, cellular, so liver cell. Carcinoma is cancer, so liver cancer. Infection is preventable by immunization. Typically, you're given 3 injections as a baby. These are your first 3 shots ever in life, and usually that provides you lifelong immunity. If you go to work in the healthcare field, they usually do a hepatitis B titer, and if you do not have protective immunity against it, they may request that you get revaccinated. Hepatitis B immunoglobulin, HBIG, is recommended for unimmunized people exposed to HBV. Serological markers. So hepatitis B surface antigen, HBsAg, It's a protein on an outer envelope of the virus. Excess circulates in virus-like particles in blood, and it's a marker for an active HBV infection. It's a component of the hepatitis B vaccine. Hepatitis B-E antigen, or HBEG, is a protein in the core of hepatitis B. It's a marker for active viral replication and indicates a high degree of infectivity. It's important to differentiate HBsAg from HBEG. Anti-HBC. So C refers to the core. So this is directed against hepatitis B core antigen. IgM anti-HBC indicates current or recent acute infection. Total anti-HBC consists mainly of IgG and can indicate a current or past infection. Anti-HBe is directed against HBeAg and indicates recovery from hepatitis B. And anti-BS indicates or is directed against the hepatitis B surface antigen, indicates immunity to hepatitis B. To keep all of this straight, I recommend drawing like a flow chart and drawing this out so that you can keep track of what the C's, the E's, the S's stand for and what that indicates, whether it's a current, past, or high replication type status that's happening. So here you can see what's happening with hepatitis B surface antigen, hepatitis B E antigen, and hepatitis B core, and the antibodies that are produced. So when you first get infected, you're going to see an increase in those antigens, and that's when you're going to start to have symptoms. Once the antigens decrease in the blood, you're going to start to see antibodies developed against them. So at their peak, you're going to start to see the development of those antibodies. Initially, it's going to be total anti-B or HBC. So that's total anti-hepatitis B core. You're going to see that IgM peak. So anti-hepatitis B core, the IgM portion or type. Then a little bit later on, you're going to see antibodies against the surface antigen, and then you're going to see antibodies against the E antigen. And you can kind of see how these would then level off. Chronic HBV infection, you would see these increase and they kind of just stay because we didn't get rid of the hepatitis B. You can eventually see that liver damage is going to be caused. Total anti-HBC would remain high. Hepatitis D virus, this is a virus that requires hepatitis B. So if hepatitis B is not there, you won't be infected with hepatitis D. It's transmitted through similar routes as hepatitis B, and it's a co-infection with HBV. Usually results in acute self-limited hepatitis, positive for anti-HDV and IgM anti-HBC. A superinfection of chronic HBV carriers, chronic liver disease with accelerated progression to cirrhosis and liver failure. Positive for anti-HDV and IgG anti-HBC. HDV RNA is a marker of active viral replication. Hepatitis C virus. It's an RNA virus with 7 genotypes, transmitted by exposure to contaminated blood, sexual contact, or perinatal exposure. Most infections are asymptomatic at first, but later develop into chronic liver disease. Anti-HCV IgG is used for screening and diagnosis. Qualitative HCV RNA is used for confirmation, and then quantitative molecular tests are used to monitor viral load during antiviral therapy. Genotyping is used to determine the best therapy. So hepatitis C is kind of known as the super latent infections. You can get it and then not have symptoms for like 25, 30, 60 years later and eventually break out in symptoms. EBV, or Epstein-Barr virus. It's a DNA herpes virus most commonly transmitted by intimate contact with salivary secretions. Begins in the oropharynx in B cells and epithelial cells and spreads through lymphoreticulaire system. It causes a spectrum of diseases like infectious mononucleosis, in other words, mono, lymphoproliferative disorders, and certain malignancies such as Burkitt lymphoma. Getting the virus doesn't mean that you're going to get all of these. It means that you're likely to have one type of disease progression based on the type of HBV that you ended up getting and based on your immune status. Mono, or infectious mononucleosis, IM. Classic symptoms: fever, lymphadenopathy, sore throat, fatigue. Laboratory findings: absolute lymphocytosis, 20% or more atypical lymphocytes, heterophile antibodies. It reacts with antigens from 2 or more species. The monospot and the Paul-Bonell test are performed. Antibodies, so early antigens, EAD and EAR. Late antigens, viral capsid antigens, VCA. So IgM anti-VCA is the best marker for an acute IM. IgG anti-VCA can indicate acute or past IM. And then there's latent phase antigens. EBV nuclear antigens and anti-EBNA appear during convalescent IM. Cytomegalovirus, so CMV. DNA herpes virus transmitted through oral secretions, genital secretions, congenitally or by transfusion or transplantation. In healthy individuals, it may be asymptomatic or induce mononucleosis-like syndrome. In immunosuppressed people, like transplant patients or people with AIDS, it can disseminate to the lungs, liver, GI tract, CNS, and eyes and cause life-threatening infections. It may cause congenital defects and decrease survival in infants. Laboratory diagnosis: direct virus detection, viral culture, identification of CMV antigens, molecular tests for CMV DNA, or serology. Serology is used to screen blood and organ donors, pregnant women. Presence of IgG anti-CMV indicates an infection. Low avidity antibodies is indicative of recent infection. VZV, varicella zoster virus. So varicella causes the chickenpox, and then if it stays in the body for a while, we call it the herpes zoster, which causes shingles. DNA herpes, herpes virus, transmitted by the inhalation of infected respiratory secretions or aerosols from skin lesions. It's preventable by vaccination. Laboratory diagnosis is usually based on characteristic clinical findings. Laboratory method of choice is real-time PCR. Serology is most useful in determining immunity to varicella zoster virus in healthcare workers, pregnant women, and organ transplant candidates. Rubella virus. It's an RNA virus transmitted through the respiratory droplets or across the placenta. It's the cause of German measles and can cause congenital abnormalities, miscarriage, and stillbirth in infants born to infected mothers. Infection is preventable by immunization. Laboratory testing. Serology. The presence of IgG is used to screen for immunity. Congenital infection indicated by IgM antibodies in fetal blood, cord blood, or neonatal serum. Current infection indicated by rubella-specific IgM or fourfold rise in IgG. Low avidity antibodies indicate a recent infection. You can do viral culture. It's not very common. And then there's molecular methods. Rubola. Rubola is different from rubella. Rubola is the virus that causes measles. And measles is much more significant. So rubella, usually you just get flu-like symptoms, you get better, and you typically recover. Rubella is usually only a major concern in the immunocompromised and in pregnant women. But rubola, or measles, causes significant disease. So RNA virus transmitted through respiratory droplets, cause of, as I mentioned, measles and subacute sclerosing panencephalitis, SSPE. Infection is preventable by immunization, and diagnosis is usually based on clinical presentation and confirmed by serology. Mumps, RNA virus that's transmitted through respiratory droplets, saliva, and fomites. That's when someone touches an inanimate object and then someone else comes and touches that same inanimate object and ends up getting infected. Most common clinical manifestation is parotitis. Infection is preventable by immunization. Diagnosis is usually based on clinical presentation. Confirmation is done by culture or real-time PCR. HTLV-1 and 2, closely related retroviruses that preferentially infect T lymphocytes. Transmission is mainly bloodborne or by sexual contact or perinatal, especially during breastfeeding. It causes adult T-cell leukemia and lymphoma, ALT, and HAM-TSP. Serological tests for antibodies to HTLV-1 and 2 are used to diagnose infections and to screen blood donors. ELISA, or CLIA, used to screen. Western blot, or LIA, are used for confirmation of positive results. Human immunodeficiency virus, or HIV, this is the cause of AIDS. HIV-1 and HIV-2 are two types. HIV-1 is the cause of most HIV infections worldwide. HIV-2 originated in West Africa and causes fewer cases. Modes of transmission would be sexual contact, contact with blood or body fluids, and perinatal. It's a retrovirus. It contains 2 copies of single-stranded RNA. Reverse transcriptase transcribes the viral RNA into DNA, surrounded by a protein coat or a capsid, outer envelope of glycoproteins embedded in a lipid bilayer. This is what the structure of HIV looks like. So it'll attach to the host cell. The main target is your CD4 helper T cells, and this is why HIV is such a problem. So human immunodeficiency virus causes an immunodeficiency. It specifically targets your T cells. In this case of HIV, it's your helper T cells, CD4 positive helper T cells. So it'll grab onto that CD4 arm and use it to get entrance into your helper T cells. A co-receptor is required. There's fusion and uncoating, and then you have reverse transcriptase, which converts the viral RNA into complementary DNA. And now all that virus is just a bunch of DNA inside of your cells. And it's really difficult for your cell to know that that's viral DNA inside of it, because DNA is DNA no matter what organism it comes from. The DNA is then integrated into the host genome as a provirus, and viral DNA is then transcribed into viral RNA and proteins. The proteins are, or the viral particles are assembled, and then it buds out of the host cells, eventually leading to the death of the host cell. There's innate defenses, humoral antibody production, and cell-mediated immunity. But it can escape from the immune response because of genetic mutations. So it's constantly mutating, generating new viral mutants with altered antigens. It can also downregulate the expression of MHC class I molecules. It can survive as a latent provirus for prolonged periods of time. And as a result, HIV persists and destroys the immune system. CD4 T cells are the prime targets of destruction, resulting in reduced effectiveness of antibody and cell-mediated immune responses. Primary infection is acute early infection, may be asymptomatic or have flu-like syndrome that resolves. High level of viremia and decrease in CD4 T cell number. Then you enter into clinical latency. Absence of symptoms, decrease in viremia, and increase in your CD4 T cell counts. Then you get AIDS, resurgence of viremia and decrease in CD4 T cell number, profound immunosuppression with appearance of life-threatening opportunistic infections and malignancies. So the virus itself doesn't necessarily kill you, but it reduces your immune system down so much that you are more likely to develop certain types of cancers and definitely opportunistic infections. So you usually die of the cancer or the infection that you got because HIV wiped out your immune system. There's antiretroviral therapy, drugs that block the virus steps of HIV replication cycle, and they're most effective when used in combination. They have significantly improved morbidity and mortality of HIV-infected people and have reduced the rate of perinatal transmission. Prevention, screening blood organ donors for HIV, education of the general public, precautions for healthcare workers, and a vaccine is currently being researched. Laboratory testing, screening, and diagnosis. So there's a previous algorithm and test methods that's different from the current algorithm and test methods. The disease monitoring, CD4 T cell count, HIV viral load, and drug resistance testing. And then there's testing of infants. The screen, we look for antibodies by ELISA or rapid EIA. And then we confirm positive test results by repeating the ELISA, followed by a Western blot. And this is the current testing algorithm. So you do the HIV 1 and 2 antigen antibody combination immunoassay. If it's negative, then it's just negative. If it's positive, then you have to follow it up with an antibody differentiation immunoassay to see whether it's HIV 1, 2, HIV, both of them detected, or neither one of them detected. In this case, you would have to confirm that by doing an HIV-1 NAT, nucleic acid test. And if the nucleic acid test comes back negative, then they're negative for it. If it comes back positive, then we know that it's an acute infection, and the patient may just not have developed antibodies yet. So principle of fourth generation HIV-1 antibody or HIV-2 antibody P24 antigen combination immunoassay. Incubate the patient's serum with a solid phase onto which HIV-1 antigens and HIV-2 antigens and antibody to HIV-1 P24 have been bound. Following incubation, HIV-1 or 2 antibodies in the patient sample will bind to their respective antigens. HIV-1 P24 antigen in the patient sample will bind to anti-P24 on solid phase. Wash, then add conjugate consisting of labeled anti-P24 and labeled HIV-1-2 antigens. Following an incubation, wash and addition of a trigger solution or substrate stop solution. Relative light units or optical absorbance are measured and confirm positive results with a rapid EIA. Disease monitoring is really done by peripheral blood CD4 T cell counts, and that's done through flow cytometry, quantitative viral load assays, and drug resistance testing. CD4 T cell enumeration. These counts are the best indicator of immune function in HIV-infected individuals. Incubate peripheral blood with fluorescent labeled anti-CD4. Analyze results by flow cytometry. In untreated patients, CD4 T cell number declines progressively, and CD4 CD8 T cell ratio is less than 1:1. CD4 T cell count of less than 200 per microliter indicates stage 3 infection, which is classified as AIDS. A significant decline in CD4 T cell count over time may indicate a need to change the CART, or the drug combined drug antiretroviral treatment, or administer prophylactic therapy for certain infections. Quantitative viral load assays are particularly done using molecular methods. HIV RNA is detectable about 11 days after infection. Genotype resistance assays is performed in clinical laboratory settings. HIV reverse transcriptase and protease genes from the RNA in the patient plasma are amplified by real-time PCR. Products are sequenced and analyzed with software for mutations. They're reported as resistance, possible resistance, or no evidence of resistance. Phenotypic resistance assays determine the ability of HIV from clinical samples to grow in the presence of antiretroviral drugs. It involves sophisticated technologies and only performed by specialized reference laboratories. So what this is saying is just because something has the gene for something, it doesn't mean that it's going to be expressed. So you can have the gene, but not actually have functional resistance, because if the virus has the gene, but it's not producing the protein that the gene encodes, then it's not going to have the phenotypic resistance or the actual physical characteristics of resistance. So that's what we're trying to determine here. Testing of infants younger than 18 months, so maternal antibodies in the infant serum can complicate serological test results. Molecular methods are used for diagnosis. Qualitative HIV-1 DNA PCR using infants' peripheral blood mononuclear cells is the preferred method. And then serological testing at 12 to 18 months of age may be used to confirm diagnosis. And you can review this summary.